So starting with the chapter 2 of removable partial dentures, and that is diagnosis and treatment planning in removable partial dentures. Like so in the chapter 1 we discuss about the various common terms which we are going to discuss in the next coming fourth classes of this unit, that is removable partial dentures, and moreover the classification systems, the Kennedy's rules, right? And then now based upon the patient's data, that is the clinical data, the radiological data, or any kind of data whatever we get from the patient, the patient's psychology, the patient's personality, all the types of evaluations what you do from the time when the patients enter your clinic till you start framing out an appropriate treatment plan based on his or her clinical condition, right? So that is where this chapter plays its important role, right? And just a second, I'll just have to change the view. Yeah, so now starting with the diagnosis and treatment planning in removable partial dentures. So now when we talk about diagnosis and treatment planning in removable partial dentures, there are usually two types of diagnosis. Okay, so the first is the clinical diagnosis. Okay, so when we talk about diagnosis, there are two types. The first one is the clinical diagnosis, and the second one is the post clinical or derived diagnosis. Post clinical or derived diagnosis, right? So now what does these two different types of diagnosis mean, right? So first, when we talk about clinical diagnosis, right, clinical diagnosis is the normal patient's evaluation about his personality, about the clinical factors, the radiological factors, which we have already discussed in complete dentures in the section 2 when we talk about the case history and treatment planning. So we'll not be discussing again all the factors, but yes, what are important and specially pertaining to your removable partial dentures we'll be discussing in this chapter. So it mainly involves patient evaluation, right, the clinical and radiographical evaluation. This is very important. Now once we have done our clinical diagnosis, next what we get is the post clinical or the derived diagnosis. Now this part of the diagnosis, which usually deals with what, it deals with the data or the data which you have received from the patient. It might be the clinical data, it might be a radiological data, right? But whatever you have derived from the patient, and along with some diagnostic tools or diagnostic attributes like your diagnostic cast, okay, the pre-extraction records, or anything what you receive additionally from the patient. So whatever the evaluation you do based on the clinical and radiographical data, and also the evaluation of the diagnostic cast, you come up to a final or a derived diagnosis, and then based on that you formulate your treatment plan, right? So the post clinical diagnosis is usually associated with evaluation of the derived data, evaluation of the derived data, and along with that the diagnostic casts evaluation is also included in diagnosis, and that is the part 2 of the diagnosis, that is post clinical or derived diagnosis, right? Now once we have divided the post clinical and the clinical diagnosis, next we'll move on to the contents of this chapter. So the contents of this chapter, what are we going to discuss? Yes, the topic is diagnosis and treatment planning and mouth preparation. The mouth preparation part is a separate chapter, so this will not be discussed today. It is a separate long answer or a question which needs enough amount of time to discuss, so it's not good to club both of them. First the diagnosis and treatment planning will be discussed, then separately the mouth preparation part will be coming up in the further lectures, right? So in the diagnosis and treatment planning, first we discuss about the diagnosis, what is the clinical diagnosis, post clinical diagnosis. Next, moving on to the consequences of tooth loss. So as you can see over here in this diagram number 2, if I will zoom in a bit this diagram, so here I have mentioned about the consequence of the tooth loss and what are the direct measures or the management procedures which we can inculcate or incorporate, right? So starting with first, that is your supraeruption or dentoalveolar extrusion or tipping. Okay, so what happens when there is tooth loss? For example, we have removed the lower molars. Suppose we have got, the patient has got extracted 3/6 or 4/6 mandibular permanent first molar. So due to the extraction of 3/6 or 4/6, any one of it or both, what can actually happen? First is there is supraeruption of the opposing teeth, right? Or dentoalveolar extrusion, or it is getting tipped. The tipping of teeth is happening. Now if you see that the supraeruption is going to be categorized based on the severity, right? It can be mild, moderate or severe. If we have a mild supraeruption of the teeth, that means the teeth has come down or erupted from the occlusal plane, above the occlusal plane, that is called supraeruption. Suppose if you want with a better diagram, this is the maxillary second molar, this is the maxillary, sorry, third molar, this is the second molar, and over here you have your maxillary first molar, which has supraerupted because the mandibular first molar is absent. So now it is separate from the occlusal plane. Now if this can be in three categories, either it can be mild, it can be moderate, or it can be severe, right? So if it is mild, you can go with coronoplasty or enameloplasty. That means you grind the teeth, the enamel of the teeth little bit, and bring it into a proper level. Second, it's moderate, you cannot grind. If you go to grind the teeth, you might end up exposing the pulp. Then in that case, you need to go with an intentional root canal therapy and then followed by a crown, right? Or third, if it is severely supraerupted, that majority of the root portion is being visible and there is no point of doing an intentional root canal treatment and then going with the crown, you can decide and take a call of extracting the teeth, right? So three treatment options for three different conditions. If it is a dentoalveolar extrusion, you can orthodontically or you can just orthognathic surgical correction can be done, but this is usually less preferred because we don't go for such a long treatment or an invasive treatment option just to place a removable partial denture. Third is the tipping. Yes, if the teeth is getting again tipped in any direction, it can be again mild, moderate or severe. Mild, you can do coronoplasty. Moderate, you can use orthodontic therapy to again upright and make it straight. Severe, again go with the extraction of the teeth. So this was about the consequence of tooth loss, like what happens after the teeth has been lost to the antagonist teeth, right? The opposing teeth, what actually happens. That is what about we were discussing of, right? The consequences of tooth loss. Now next, moving on to the second important part of this chapter, that is clinical evaluation of existing disease. See, now when we are planning to fabricate or place a prosthesis, right, in that case we need to evaluate if there is any presence of existing disease or condition which might hamper our treatment plan or the design of prosthesis, or it might not let the RPD be a successful prosthesis for that patient, right? So in that case, we have various points which we need to keep in mind, like the periodontal health, the amount of attached gingiva, the occlusion, the endodontic status, and the radiological examination of the patient. So now we'll be moving with discussing these 5 points, right? Firstly, starting with the periodontal health, right? So when we talk about the periodontal health of the patient, right, so periodontal health involves various aspects. Okay, first I'll write the heading, periodontal health. So now when we talk about periodontal health, it involves various aspects like oral hygiene, where you take your plaque index, gingival index, right, periodontal index. These are usually done to measure what? Gingival inflammation or bleeding on probing, right? Or if there is any periodontal breakdown, right? Periodontal breakdown of the teeth, right? Or if there is any mobility or trauma from occlusion. So all these things or all these parameters are to be evaluated when we consider about the periodontal health. We have our oral hygiene index, plaque index, gingival index, periodontal index, or one more which I didn't mention, that is the Russell's index, which is mainly targeting on evaluating the amount of periodontal breakdown in the tissues, right? So all these examination procedures like probing depth, bleeding on probing, you can use a force meter to detect the amount of force exerted on the teeth when it is mobile. We can also evaluate the vertical, this is the vertical bone loss, right? Vertical bone loss or horizontal bone loss, right? So vertical horizontal bone loss can also be considered as a factor of periodontal health, because all these are somewhere or in some or the other way going to affect our treatment plan. So that is what is about the periodontal health. And after evaluating the periodontal health, the clinician can come to a conclusion, right? You can come up with two conclusions. First, that not extract the teeth, right? Second, you can come up to a conclusion that extraction of teeth. So based on evaluating the risk and the severity and the consequences, we can come up with a decision that we want to extract the teeth or save it and include in the arch and give the prosthesis according to that clinical scenario. So this was about your evaluation of periodontal health. Now second thing which is important over here is the attached gingiva. So when we talk about the attached gingiva, we'll again discuss attached gingiva in various terms: the introduction, the width, the functions, the methods of measuring the attached gingiva. That can be anatomical methods, functional methods, or histological methods, right? So moving on to the attached gingiva. So firstly, what is attached gingiva? This is a very common thing to know, that what is attached gingiva. So if I start with the definition of attached gingiva. So what is attached gingiva? It is that portion of gingiva that is firm, dense and stippled, and it is tightly bound to the underlying periosteum, bone and the tooth. So that part of gingiva that is firm, stippled and dense, which is tightly adhered to the underlying alveolar bone, tooth or the periosteum. Okay, clear? Simple definition. More you will learn about attached gingiva in the subject of periodontics, but yes, this is a common definition which we should keep in mind. Now how do you evaluate the width of the attached gingiva? So firstly, if you want to demarcate or locate the attached gingiva, it usually starts just after the gingival margin till the mucogingival junction, right? So mucogingival junction contains of a movable part. So the junction of the movable and immovable part from there till your pocket depth, the gingival pocket, the free gingival margin, that area over here is your attached gingiva. Now usually the width of the attached gingiva, if we talk, so if we talk about the width of the attached gingiva, if we talk about the normal values of maxillary anteriors, it is 3.5 to 4.5 millimeters. Okay, and for mandibular anteriors, it is 3.9 to 3.5 to 3.9 millimeters. Okay, pardon me. And this was about the anteriors. If we talk about the maxillary premolar areas, then it is about 1.9 millimeters in average, and for mandibular premolars it goes around 1.8 millimeters. Okay, so this is the normal width of the attached gingiva. Now what are the functions of your attached gingiva? How does it help us, right? So when you talk about the functions of attached gingiva, just to brief out, we are not going to go into the detail because this is more of periodontics, but a basic knowledge should be there if you are a prosthodontist also. The basic areas are going to help you in the clinical dentistry. Okay, so it's not a subject wise approach which we will carry. We will carry an comprehensive approach towards the subject so that we can relate the things in a more better way, right? So starting with the functions of attached gingiva, first is the aesthetic function, right? So that smile, that pinkish stippled dot dot appearance gives more confidence to the patient or gives an youthful appearance, right? Second is prevents bleeding. Okay, how does it prevent bleeding? Okay, so if there is good amount of attached gingiva, there are less chances of infection and invasion by the microorganisms, where the bleeding on probing will be less. But where there is less of attached gingiva, there are more chances of pocket formation, depth, invasion by microorganisms, leading to bleeding and other factors. Okay, so it also decreases plaque accumulation. As I said, accumulation is decreased. And the fourth one is it decreases the amount of gingival recession, decreases the amount of gingival recession also. So this was about the functions of attached gingiva, the width, the basic or the normal range of the width, and the functions and the definition. Sorry. Now moving on to the various methods of evaluating the attached gingiva. Right. So there are various methods. You can divide it into three segments: the anatomical, the functional, and the histological method. When we talk about the anatomical method, we have a probe walking test, inspection or palpation, and ballooning technique. So we'll start first with the inspection and palpation. I'll try to verbally explain you what is inspection and palpation, right? So in inspection, what happens is you need to pull out the lips of the patient. When you pull, you can see demarcate the junction of your movable and immovable mucosa, right? Movable mucosa is demarcated by the junction called as mucogingival junction. That is the junction between the mucous membrane and the gingiva. So when you move the lips, you will see the movable part, that is your mucosa. The just below it, the immovable part is your attached gingiva, like we see in this image. See, all this is the movable part. Above this over here is the immovable part. So that is how you palpate and inspect the attached gingiva. Then there is something called as probe walking test. So this, with the help of a probe also, it can be evaluated. You need to actually measure the distance. Suppose in this diagram, if I want to explain, I'll just erase all this stuff. Now I take a probe and I measure the distance from, so I measure a distance from the gingival margin till the mucogingival junction. Suppose this distance which came is of around 10 millimeters. Okay, from gingival margin to mucogingival junction is 10 millimeters. Okay, now there is something called as free gingival margin and the pocket. So I will measure the pocket depth. Suppose pocket depth I am measuring, and I am getting pocket depth as okay, so pocket depth is 5 millimeters. Okay, pocket depth. So now I have to minus 10 minus 5, that is 5 millimeters. Okay, so from the base of the pocket till the junction of the mucogingival area, that is 5 millimeters, and remaining 5 millimeters is the pocket. That is how, with the help of probe, you can measure. Third is the ballooning technique. Okay, where you inject the local anesthesia, and that part of the alveolar mucosa will try to balloon and swell, and with that also you can evaluate the attached gingiva. But with the help of inspection and this probing technique, it's the most useful method which we carry nowadays also. Then based on the function, you can do the tension test and the roll test, right? In the tension test, what you do is you just try to, as I said during the inspection also, but in this you provide tension on the lips, you pull the lips, retract them nicely, and see that which area is getting tensed and pulled and which area is not getting pulled. Based on that you evaluate, because attached gingiva is immovable. The mucogingival junction or the lip area or the mucous membrane is movable. So when you pull or retract the lips, that movable area is stretched and the immovable area is seen. So that is how they evaluate. Then the roll test. Okay, the alveolar mucosa will usually tend to roll up over the attached gingiva because that is firm and dense over there. Okay, histologically, there is one technique, that is staining Lugol's solution. So what you can do is you can take a cotton swab, okay, and take a Lugol's solution and paint it over the area. So the mucosa will take up that staining, okay, the brown staining, because there is presence of glycogen. Okay, so if I will write over here this Lugol, sorry, yeah, this Lugol's solution, right? This is going to stain the mucosa brown. Okay, when it stains brown, that is due to glycogen present, but it will not stain the attached gingiva. Okay, so that is how you can demarcate which is the attached gingiva and the alveolar mucosa. Okay, so this was about the methods of evaluating the attached gingiva. Then next, now if you want, if you know or if you are aware that the amount of attached gingiva what you evaluated or what you perceived from the patient is inadequate and you want to plan an RPD, then what are the steps or the measures which you can take or consult a periodontist for this and come up with a good treatment plan, right? So if you are not planning an RPD, no issues, no worries, then no need of knowing about the management of the deficient attached gingiva, right? Because there is no augmentation required. But if you are planning for a removable partial denture and if you see that the attached gingiva is less than 3 mm or if the attached gingiva is more than 3 mm, again no augmentation required. You can directly go on with fabricating a removable partial denture. But if the attached gingiva is less than 3 mm and if it is adequate for abutment, then again no require of augmentation. Okay, if you feel that that amount of attached gingiva, though it is less than 3 mm, but it is sufficient for my abutment teeth, then no need to go for augmentation. But if you feel that the augmentation is required and it is not sufficient for an abutment, you have two options. First option is a connective tissue graft, second guided tissue regeneration. Connective tissue graft can be taken from apical augmentation or root coverage grafts, subepithelial connective tissue grafts or free gingival grafts. All of this will be discussed more in periodontics, right? So this is what you can evaluate based on the amount of attached gingiva and make your clinical decision about the treatment plan, right? Now next, moving on to the next factor, that is occlusion of the existing teeth. Now again occlusion is very much important, right? So if we talk about occlusion of existing teeth, so what are the prerequisites which should be present when we talk about the occlusion of the existing teeth? So the first thing which comes up in a mind is that it should have, or the occlusion should represent a good cusp to foci relationship. Okay, so cusp to foci relationship should be good enough. They should interlock properly between each other, right? As we see in this diagram A over here, good interlocking of the cusp and the fossas should be present, right? Sometimes you might encounter a tilted or a mal-aligned teeth. Okay, so such teeth can either be orthodontically treated or can be extracted. So mal-aligned teeth, what you can do is orthodontically treat it or proceed with extraction of that teeth. One more thing which you need to be aware about is trauma from occlusion. Okay, trauma from occlusion. Sometimes due to trauma from occlusion there are chances, right, that there might be high points or occlusal prematurities. To be more scientific, occlusal prematurities. Okay, somewhere some point of the teeth will be interfering, that is called as occlusal immaturity. There can be mobility of the teeth. Okay, mobility of the teeth can be present. Then buttressing bone formation can also be there. See, this is called as buttressing because more amount of force is directed from this side. This part of the cortical bone will show a buttressing bone formation. So these factors should be evaluated when we are talking about the occlusion of the existing teeth. Then moving upon the conservative and endodontic status of the existing teeth. Conservative and endodontic status. So now this again plays an important role because dental caries being a most common or a primary pathology which we come across as a dentist, right? So you need to effectively check the vitality of the teeth, right? Check for carious lesions or endodontic lesions. Check for vitality of the teeth with a pulp tester, okay? And moreover, any fractures or chipping off of the crown, that all should be corrected, right? And moreover, if you are coming up with a decayed teeth or a root stump, okay, so in that cases you can go with RCT, then post, and then core buildup, right? That is what is shown over here. So if you can build a teeth, post and core buildup, and then you can go with it using as an abutment also. This much about the conservative and endodontic management. Lastly, the radiographical examination, we should keep in mind about the tilted or impacted teeth which are present root stumps or any endodontic or periapical lesion. So this is about the first part, that is the clinical diagnosis in diagnosing as well as treatment planning of a removable partial denture, right? So till now we have discussed about the clinical diagnosis part.